Welcome to Conspiracies Against Wellness with your host, Janelle Elgaway.
And now the host of Conspiracies Against Wellness, Janelle Elgaway.
Good evening and welcome to Conspiracies Against Wellness on the CAW 360 Network. I'm your host, Janelle Elgaway. There are two ways to listen in to tonight's program: through our website, www.cawnation.com, or YouTube channel, Conspiracies Against Wellness Livestream. Make sure to please subscribe to our YouTube channel to get reminders of when we are on live. If anyone would like to call in with questions this evening, you can do so at 415-403-2715. And now I'd like to welcome our guest, Dr. Glenn Gittleson. Dr. Gittleson, how are you this evening? Hello, Dr. Gittleson?
Oh, yeah, hi.
Oh.
Hi, I'm sorry.
Huh?
Jenna, hi. It's my pleasure to be here.
Oh, we're so happy to have you. I have looked for a dentist for 2 years to come on to the program, so I am so excited to have you. Could you please tell our audience a little bit about yourself, about your background and what you do?
Yeah, sure. I'm a general dentist. I've been in practice for about 36 years now. The last 18 years, my practice has been really just specializing in diagnosing and treating patients with TMJ-related disorders, growth and disorders of children, where their faces don't grow right, and specifically patients who have suffered from complex regional pain syndrome known as CRPS. I treat children, adolescents, and adults. I received my training at the Piper Education and Research Center down in St. Pete, Florida. That's an ongoing event. I'm down there studying with Dr. Mark Piper probably 4 times a year at least, constantly upping and re-upping training and knowledge. It's an ongoing event. The knowledge gain never ends. You always have to study this stuff to stay on top of it.
Absolutely. So how did you actually start getting into the CRPS and TMJ world from being a dentist?
Well, interesting because, you know, as a dentist, you treat different kinds of pain to the head, neck, and face. And what I came to realize, number one, is that the jaw joint and then the sympathetic nerves play heavily into anything we do as a dentist. Unfortunately, it doesn't get recognized enough that jaw joint function is critical to anything we do as a dentist because it has to do with the bite, and we deal with that every day. And then sympathetic dysfunction, meaning CRPS, actually plays very heavily into anything we do every day, diagnosing pain, patients with jaw joint dysfunction, patients with bite issues, patients with problems with their gums. Any branch or aspect of dentistry can be affected by the sympathetics and CRPS, just like it can affect any part of the body. So it caught my eye many years ago, and then having the Piper Education Research Center as my go-to place to learn and continue to learn is something I chose to do, and it's worked out well. I've been able to help a lot of people who otherwise were lost for quite some time.
Right. So why is CRPS so difficult to diagnose and to treat?
Well, so that's a great question because it really isn't. Historically, CRPS, if you go back to last century, it actually was really first well-defined during the Civil War. That's from 150 years ago. But what happens is that it was really treated like a moving target. The medical profession could not agree as to how to diagnose it or even what it is. However, in 2007 and then specifically 2013, from the works and publications of Hardin, they came up with a specific criteria known as the Budapest criteria. It's just named after where their meeting was held, but they gave specific concrete guidelines to diagnose CRPS, because the most important thing to understand about diagnosing CRPS is early diagnosis is critical to prevent it from spreading and getting worse than it has to be. So you can diagnose it specific, but you have to know that that diagnostic criteria is available. And unfortunately, every aspect of medicine, dentistry, branches of medicine, podiatry, chiropractors, name it, just don't seem to be familiar with this. There are some that are, but the key point is early diagnosis is critical. There are categories of symptoms, and it's a clinical diagnosis. You're not going to get it from imaging of MRIs and CTs. You're not going to get it from blood work. You always have to rule out other diseases that might be causing the symptoms the patient is having. But when those tests are negative, rather than throw up your hands and say, I don't know, you start to think of sympathetic dysfunction, CRPS, because CRPS will be the only disease entity that will explain all of the aberrant symptoms that a patient is having.
Right.
And I'll tell you the reason. Well, I can tell you. What's that? Sorry.
Sure. No, go ahead.
Well, I was going to say the reason for that, the reason you can get such a spread and diversion of symptoms is because the sympathetic nervous system governs body temperature regulation, blood pressure, pulse and respiration, and all immune system function and all glandular function. So every part of the body receives a sympathetic supply, and every part of the body, therefore, can be susceptible to a sympathetic event in the form of CRPS, where you'll have some form of dysfunction occur. So one day a part of the body could be hot, one day a part of the body could be cold. One day you can have swelling, one day you can have pain, one day you can have skin rash and skin alteration, and it can change location and it can change duration, and the nature of the symptom can change, because CRPS, in a nutshell, is known as the disease with a mind of its own. It's a horrible affliction, and the most important thing is early diagnosis. And that's where this Budapest criteria that was published in 2013 formally should be known by anybody in a diagnostic arena, really, at this point.
So what is the Budapest criteria for those that don't understand what it is?
Okay, so in a nutshell, you have categories of diagnostic variables. So one of them is, does the patient have disproportionate pain from an injury they sustained? In other words, is the pain you're having, is it higher than it should be, and is it not going away? That's one category. Then there's sensory pain. That is, patients can have different types of pain. There's hyperesthesia, which is sensitivity to the senses. Some people with CRPS, they cannot take light. They cannot take certain sounds. They cannot take having their skin touched. There's hyperalgesic pain. That means exaggerated pain to a mild pain stimulus. Then there's allodynia. That's pain to a non-painful stimulus. So these patients have these distorted senses of pain. They have vasomotor symptoms, which has to do with body temperature regulation, where the body, literally one side of the body or one part of the body can be white and cold, and another side can be red and hot, because you have areas of the body that are vasoconstricting. The sympathetics cause vasoconstriction of blood vessels. They're basically what are called hitchhikers. The sympathetic nerves travel along arteries, and they exert their influence by constricting blood vessels. When you constrict blood vessels to an area, you're going to pull blood deeper, and skin, as for instance, will turn white and get cold. It's part of the body's attempt to preserve body temperature. Another side can turn red and hot because the body's trying to release temperature from that side, and therefore when it's dysfunctional, one part of your body can be one way and another can be another. Then there's pseudomotor. Pseudomotor has to do with fluid. There can be swelling to any part of the body that doesn't resolve. You can have swelling in your fingers. It can be to another part of a limb. It can be swelling where your sinuses are blocked up, where an ear leaks fluid out of it, where an eye can tear, and there's no sign of pathology, and there's no illness, no infection, yet they still have this swelling and these leakages type things occurring. They can be sweating from one part of the body, one side of the head. It's just all aberrant function. Then there's motor or trophic changes. That's where people have muscle dysfunction, and that's dystonias, where they can have a spasm, where they can have weakness, where they can have tremor, and that can be to the eye and to the face. I see it all the time, twitching and quivering. Or they say, my hands are weak, I can't even open a jar anymore, when they have a flare-up. And that's because the sympathetic dysfunction has hit them that way. So you can have all kinds of dysfunction, and it can show itself in any way it wants, at any time it wants, and then change location, duration, and intensity. It's the nature of the beast. It's called a disease with a mind of its own. It's a horrible disease to get caught up into.
Yeah, I've never heard of that. Now, I've heard like the suicide disease, but I love that because it really is true. I have CRPS in both my upper limbs and my face, my mouth, and my head, and I've lost hair in the past. My teeth have literally just broken apart and became brittle and fell apart. Why does that happen with my mouth? And how do you help someone that comes into your office and says, I have CRPS in my mouth and I don't know what to do?
Right. So that's a great question because it's so critical. I hear it all the time that patients are afraid to go to the dentist because either they've been told or they've had their crypts get flared up when they might have been in more of a remission state because they had a dental procedure done. And it's not so much the dental procedure as it is your reaction to it. Because in the literature, and I've had patients come in, you can have a tooth bonded, a pure cosmetic procedure, non-invasive, and light up an entire crypts episode it can start in your mouth where you can say, well, my bite now doesn't feel right, where my gums are red and irritated, my teeth are hurting me, things like that. Or you get a specific, very high-end toothache, but there's no reason for it. And the mistake that gets made, if the CRPS thought process is missed, is that people end up getting root canals, they get extractions, they get procedures done that did not have to be done if the CRPS component of the problem was picked up. So again, it's a clinical assessment. There's no fancy diagnostics. It's just understanding to think ahead and beyond what this patient is presenting with. So if the sympathetic...
So let me ask this. Okay.
Go ahead.
Go ahead. I'm sorry.
Oh, I was just going to say that the reason people get
the sympathetics, yeah.
The sympathetics is what can create this high-level pain, and it can localize itself in teeth. Because if you get vasoconstriction to an area, you're going to take away blood supply, you're going to take away oxygen. That creates an inflammatory response. That creates fluid buildup in teeth. That'll give you a terrible toothache, but it's not the tooth, it's the sympathetics. And if you get a procedure done to try and arrest it, you're actually going to make the whole thing worse because every procedure you have done is going to be viewed as a trauma and stimulate the sympathetics. Every time you get cut, every time you get stuck, every time you have something done, the body is going to respond with its sympathetic response because that's the job of the sympathetics, the flight and fight. It's designed to keep the body functioning, but when it's aberrant, it's going to do dysfunctional things to you and create pain, spasm, temperature changes, weakness, skin sloughing, name it. There's a tie-in of skin, hair, nails, and nerve tissue. They all come from ectodermal tissue from when you were embryo, from way back.
So you mean to say, so I've had to get in the last few years over 22 root canals and then crowns because my dentist didn't understand what CRPS is, one. And then the second thing is like, I had one tooth pulled in 2013, and then it seems after that's when all my teeth just started having major issues, and this started to happen. So, I mean, not only that it's super expensive, but so I didn't really have to get all these root canals. Then you're saying,
Well, here's the thing. Now, I never saw your mouth. To be fair, I never saw X-rays of your mouth. I never done a proper exam. But you have to say to yourself, what are the chances of you truly needing? If you're saying you had how many root canals you had done?
I had like 22, 23 of them.
Well, there's 36 teeth in the mouth, including the third molars.
Most of them.
You had most of them. What are the chances of you truly needing a root canal in every tooth? Probably not. I mean, because the reason you need root canals is either decay into a nerve or a nerve going bad, which could be due to trauma and such. But if the crypts hit you in the mouth and you get what's called compartment syndrome, well described in the literature, you could feel like, he thought, or you presented like it's a root canal type event. But I will tell you, if you block the sympathetic nerves to the mouth, which is very easy to do, you would see that pain in your mouth go away. That takes us to the diagnostic nerve blocks that are very easy to do. You don't have to be in a hospital. I do them right in the dental chair. They're peripheral subcutaneous injections on the sides of the neck. I know what nerves feed the sympathetics to the mouth, and if somebody comes in with high-level pain, I'll block the sympathetics, and depending on what goes away, tells you how much of that sympathetic contribution how much contribution is coming from the sympathetics. So you have to always think out what's going on.
Okay. Right. So say if I go to my dentist dentist, and I know I have CRPS in my body. What are the symptoms that I have CRPS in my mouth now? How would you know that I have CRPS?
Okay. Right. Well, what I'll be looking for, first, if you tell me ahead of time that you've got CRPS, and now I'm also having this problem in my mouth, your gums could be red and swollen even though your hygiene is pretty good. Teeth can be hurting that have no reason to be hurting. Your jaw movement, you could say, I can't get my teeth together, or my jaw keeps clenching all the time, or I'm quivering, I can't even move my jaw properly. Those are signs where there's muscle dystonia, which could be modulated by the sympathetics. So the answer is not to start making appliances and muscle relaxants and all these things, because you're treating before you're diagnosed. Again, these diagnostic nerve blocks are so easy to do. Anybody can learn them. You know, any dentist or any doctor, anybody, any nurse, anybody who's licensed to inject, who can give an injection, can learn these blocks, and any dentist should be able to do them. Because if you come in and say, I don't know what's wrong, my gums just hurt, my teeth just ache, or you know, if a little bit of cold gives you a walloping toothache, and the first impulse is to think, well, the nerve's going bad, get a root canal. Not necessarily. It depends on, you know, what's the history on the tooth. If there's no filling in that tooth, if there's no trauma to the tooth, no wear, if there's no reason for that to be, you think sympathetic, block the sympathetics, and see if the pain goes away. You cannot just give a regular injection in the mouth to test for sympathetic dysfunction, because the injection in the mouth is primarily numbing sensory and not sympathetic. You got to catch the sympathetics from outside the mouth. So if you come in, two things. Number one, with sympathetic type dysfunction, whether it's muscle or tooth or gum or, you know, something's not right, I would block the sympathetics to see if that's the problem. And number two, more importantly, if you came in just for routine hygiene, just for routine check, or for any filling, for any procedure, preemptively, I block the sympathetics before your dental procedure. That's how I treat the CRPS patients. I block the sympathetics before and part of that dental procedure. I'll use the same local anesthetic we use in the mouth, nothing fancy, just a local anesthetic that's given to block the sympathetics on the side of the neck where those nerves will then branch and come into your mouth. We catch them outside, and that will stop the sympathetics from reacting to whatever you have done in the mouth. That's how you can keep it at bay. Now, if somebody has is really in an acute phase of CRPS and has to have something done, then I might block them the day before. I might put them on certain medications. We might try and, you know, quiet this thing down a little bit. And then I might block them the day before, the day of, and the day or two after, because you can give these shots consecutive days. There's no real limitation other than you can get a little bruising, a little soreness in the side of the neck where they're given. That's really about it. It really works quite well. I've been doing it for quite some time.
What is TMJ, and what is the relation of TMJ and CRPS in the mouth?
Okay, so now that's a great question. To me, TMJ is not some syndrome where people say, I clench, I grind, I have headaches, I'm under stress, was told to have TMJ. As soon as you say the abbreviation TMJ, you're talking about the temporomandibular joint. That's the joint in front of your ear that relates your lower jaw to your skull. And it's the only joint in the body where the left side is connected to the right side, which means one side can influence the other. So the only way to properly diagnose the jaw joint is just like any other joint in the body, is with MRI. And you need a protocol that will relate the jaw joint to what's happening at the level of the bite and to any potential pain patterning. Now, when you start putting CRPS into there, the problem is that if you get a muscle dystonia where the jaw joint and the muscles that control it are being controlled by the CRPS and the sympathetics instead of the normal fifth cranial nerve, which is what would control the TMJ area and the muscles and movement and such, you're going to get aberrant function of the jaw joint and in your mouth when it has nothing to do with the TMJ. So what MRI does when you say I have TMJ is we read the MRI, and is there a problem with the anatomy? The only way to know is to image it. You can't guess. You can't feel it. You image it because you get a 3D image of hard and soft tissue. That's the gold standard since 1987 when MRI became available. So anything less than that is, A, to me, it's last century diagnostics, and B, you're guessing. So when you can see the anatomy, and if it's been disrupted, and if that disruption is creating a potential problem, A, it might be part of what's contributing to the sympathetic problem, and or B, it could have no problem, and it's just the sympathetics that are causing it. It's the same thing. We have to look at neck, because when people injure their joints and their TMJs, they often injure their neck as well. So you have to understand the contribution from neck to joint, joint to neck, and sympathetics to the whole area. So it all ties in together. You cannot look at one or think of one without examining it and accounting for the other as well. In a nutshell, it's nothing complicated. Truly, it's just things you have to know. Just like a big jigsaw puzzle putting together.
We're going to take a quick call if you don't mind. Caller from area code 843. Welcome to Conspiracies Against Wellness. What's your name and what's your question for Dr. Gittleson?
Hi, this is Tammy. I was diagnosed in 2013 with CRPS, and prior to that, I had great teeth. Since then, every year I go to the dentist and have my x-ray done. It's showing anywhere from 11 to 13 cavities. I have them filled, go back the next year, again, 11 to 13 cavities. I'm down to 16 teeth now.
So you've had the teeth extracted secondary to the decay where they couldn't...
I had to, the ones that have been pulled, yes.
I mean, have you had anything to replace those teeth? Any implants placed or anything? Have they done anything?
No. I had talked to him about dentures, and he said, let's wait and see what's going on, because he can't figure out, I had asked him if it was related to the CRPS, and he said that he doesn't know. He's not familiar with it.
Right. Well, the only thing I could tell you, number one, with sympathetic dysfunction, your saliva rate can go down. And if you have even a normal diet, if your saliva rate goes down and I don't know your home care, but if you lose the body's ability to cleanse itself in the mouth, that could contribute to a higher decay rate. When people lose salivary function, which can go down, the sympathetics create, you lose your you lose your salivary secretion. That's part of what the sympathetics do. It's the parasympathetics that would bring it back. But decay, the teeth aren't going to break down themselves. What can happen is the bone can start to break down when you have CRPS, because you lose blood supply to the bone and you get more blood. You actually get more marrow spaces in bones, so bone's more prone to fracture. But any procedure you have done, you're just going to get a delayed or poor healing. That's why I was asking about implants, because implants are really, if your active crips are contraindicated, you really don't want to do any invasive procedures. So
right, I had a tooth pulled in November, and literally it was after Christmas before it stopped hurting.
Yeah, you know why? Because you have delayed poor healing, because you have poor blood supply. CRPS is a vasoconstrictive event. The blood supply is compromised, and also the immune system is governed by the sympathetics. So depending on how active your CRPS is and how it's hitting you, you can have poor response to healing. You can get infections. It's just a matter of how your immune system is functioning, because it's governed by the sympathetics, as is blood supply. But as far as decay goes, the only thing I could think is you can have poor saliva flow, and that could lead to more bacterial retention on your teeth if you have a sugary diet and things like that. That's off the top of my head.
Okay. Pain management seems to think that it's the opioids that are doing that. Is that possible?
Well, how are the opioids causing you to have tooth decay?
I have no idea.
Well, tooth decay is bacteria related. If teeth break down, it's the acids from the bacteria. They live off the food in your mouth. There's always bacteria, and if your teeth have little cracks and crazes in them, another potential, if you clench, you can get micro cracks that you can't see to your naked eye, but to the bacteria, that's a big opening, and they can start to get in there. But if there's bacteria do you notice in the morning, is your mouth really sort of dried and
very
feeling? Okay, so did the dentist ever prescribe? There are prescription level antimicrobials that you can use that will hold the bacteria in check overnight. PerioGuard, Paradex, things like that. They're prescription, but it gives you like a 6 to 8 hour kill. So if you rinse with it at night and floss and brush, and then use it again in the morning, you can really control the bacterial count in your mouth. As but one instance that could try and help you a bit.
Okay, thank you so much.
Thanks for calling in, Tammy.
Thank you.
We had another question from KCD. She wanted to know, she says she had a bad stroke, and She has TMJ as long as she can remember. All of her crowns have fallen out because of bone loss TMJ. I can't get regular dentures because my face is so tight it pushes my partial out. Why is this not covered under medical or Medicare? I bought a supplement insurance, but it's almost worthless. Any suggestions for so many of us who are living like this?
Okay, so separate from the insurance part, when your muscles are real tight, if they can't get that under control, that's where nerve blocks come in. Because if those muscle spasms in your face are sympathetic maintained, and again, that's where MRI of your TMJ, someone's telling you you have TMJ because your muscles are tight. I mean, you don't know what the status of the joint is until you have MRI. I've had patients who had jaw joints that were ankylosing, meaning just growing bone and freezing the joints, and they were told it's muscle, and it was absolutely was the joint, and then the joint could be normal, but your muscles are just in spasm, which could be from the CRPS. If they're that tight, I would be dumbfounded if there wasn't a sympathetic component to it, and therefore the easiest thing in the world to do are these sympathetic nerve blocks. Again, they're peripheral nerve blocks on the side of the neck over the sternocleidomastoid muscle. That's the big neck-turning muscle right under the skin at the level of the jaw. I'm sorry I didn't send you any diagrams. They're very easy to do. And they take, in a few minutes, they start to take effect in the chair. And I use them, again, preemptively before I'll do a dental procedure on a CRPS patient, but also to treat their CRPS, because you'll get an effect to the head, neck, and face. I get effects to the upper body. It's called the brachial thermatome. I know you have that thermatomal diagram. There's the carotid thermatome, which is the head, neck, and face. There's the brachial thermatome, which is your shoulders, chest, arms, shoulders, hands, and fingers. And it's amazing to see the release that people will get, where edema will go down, muscle spasms release, pain goes away. So if your muscles are that tight in your face and they're telling you can't have something done because your muscles are so tight, then get to the source of it. Or any problem you have can be traced to its source. All pain can be traced to its source. All these dystonias can be traced to their source. And the way you do it is with these diagnostic nerve blocks. And I promise you, any dentist or MD can be taught to do them. And see what happens. That's why they're called diagnostic, because you give it and see what happens and see what kind of results you get. Minimal risk, maximum benefit. That's the way I present it.
How long do these blocks last that you give to your patients?
So that's a great question. So when somebody comes in and a diagnosis of CRPS is made, and I want to do these diagnostic blocks, we do them to see how much help can I give you just from the block. And then the first thing, that'll happen in the chair, and we'll see how much relief do they get. That relief can sustain itself. Now, it could last for the duration of the anesthetic, and I'll use up to Marcaine, you can get up to 6 to 8 hours of numbing effect of the sympathetics. And then I'll let the patient tell me, are you still feeling relief the next day? The day after that, maybe a week. It can go for days, weeks, and months, or it could be the length of the anesthetic. Depending on the amount of relief and the duration will dictate what I would do next. If they get a good effect from the block, I'll repeat the block. You can do them once a day. If I ever had to, I would do it twice a day, as long as I spread it out by at least about 10 hours. But usually once a day for a couple of days in a row, plus medicine, plus physical therapy, plus the diet. Remember, you can't just do one thing to treat CRPS. You've got to surround it and hit it as many ways as you can. And the diet modification is very important, because there are foods that stimulate the sympathetics. And I tell patients, if you go home, as an example, and eat a chocolate candy bar, a Hershey's candy bar that contains phenylethylamine, that's what chocolate has in it, and that stimulates the sympathetics. It stimulates the secretion of epinephrine and norepinephrine, which is the chemicals that feed the sympathetics. You can override my nerve block. You'll just shut my block off by having too much epinephrine in your system. So there's a multiple-prong approach to treating patients. So if somebody has dystonia to their face, that muscle tightness that you're describing, you got to go after it. You don't say you've got. It's not. TMJ is not a diagnosis. I guess that's the most important thing I can tell you. Tell me what's going on with the joint. Tell me what's going on with the bite. And then if there's pain, tell me where the source of the pain is. All pain can be traced to its source. All things can be figured out. You just have to look. And then peel back layers, keep looking, beyond the most obvious to the next thing and to the next thing. Okay, but I will tell you that there's 3 main nerves that go to the head, neck, and face. 2 are from the neck and 1's from the 5th cranial nerve, and then there's the sympathetics. And you can block any one of those and start to separate out what's happening with any patient.
Okay. People are asking, what is the antibacterial rinse called that you use? Is it Paradex?
Oh, no. Paradex is one. Peridex. It's prescription. The one that I like, I'm not looking to be commercial. PerioGuard is what I prescribe from. It's from Colgate because it has a nice minty flavor and it doesn't stain the teeth. But what it does is it's chlorhexidine gluconate is the active chemical. It gives you a good 6-hour kill of bacteria in your mouth. So if you floss and brush your mouth at night, rinse for 30 seconds with a half a cap full that comes with a white measuring cap, you'll wake up in the morning and you won't feel that gunky, sticky plaque buildup in your mouth. So if you do it at night and do it in the morning, your breath, besides feeling fresh, it'll also really keep the bacterial count low in your mouth. So that's another thing we do with patients who are showing signs of increased decay and such, is get them on an antimicrobial and also saliva substitutes if we have to, whatever it takes. It depends on what they present with.
Okay. We are going to take another call. Caller from area code 269. Welcome to Conspiracies Against Wellness. What's your name and what's your question for Dr. Gittleson?
It is Jesse Ray Janelle, and I've got a question for Dr. Gittleson, if
Okay.
I'm pronouncing your name
That's
right. I've had a lot of sinus infections, and I've just had 2 teeth pulled back March 5th, and I was wanting to know if, based on what my oral surgeon said, those sinus infections might have led to the severe decay to end up having to have those teeth pulled because they broke into numerous pieces.
All right. Well, the teeth breaking in your mouth, I mean, that could be related to your bite. That could be related to decay in the teeth. That would be the reasons they would break. Now, you're talking about top teeth, upper teeth?
Bottom. I had 2 bottom ones.
Well, the sinuses are on the upper jaw, so a sinus infection isn't necessarily going to affect the teeth in the lower jaw. But if you had opposing teeth and you're talking about the back of the mouth has the highest bite forces. So if there's a problem with the bite, if there's a problem with clenching and grinding, whatever the reason might be, that's how you can break teeth. Okay, and then if you crack them and you can break a filling or you can break a cusp and teeth can start to break down, but a sinus infection, to my knowledge, is not going to affect a lower tooth. Sometimes the roots of upper molars can be literally in the sinus, so you can have a sinus infection that could involve the roots of an upper back tooth, but it's not likely, in my opinion, just from what you're telling me, that a bottom tooth could get infected from a sinus infection in the maxillary sinus. I can't picture that. Okay.
Okay.
Did you have any other questions, Jesse? Okay. Thanks for calling in.
No, thank you.
Okay.
Bye.
Bye-bye. I was wondering, the blocks that you do, are they covered by insurance? A lot of people are asking. In the mouth.
Right. Okay. So here's the problem with insurance. The misnomer is I have insurance, everything is covered, and that's just not true. There are codes, thousands and thousands of codes, dental codes, medical codes for everything you might do for a patient. However, the insurance carriers don't recognize they say these codes not covered in this plan. And most of the time, so they can always give you for your checkups and your cleanings and basic procedures, and same thing in medicine. But when you get into the more high-end stuff, like there are dental codes for these nerve blocks. And when I submit for somebody, it comes back this code not covered, so they get 0 back. And it's not to me, it's not fair to the doctor who's taking all the time to do this stuff, and then not to have reimbursement. So I'll be honest with you, I practice as a fee-for-service, and if you have insurance, I'll submit it for you. We always submit the insurance for the patient, but if you don't get back anything or you get back, minimal, then that's because that's how your insurance is geared. They're just not recognizing these codes. It might change in the future, but I never understood why do you have all these codes if you don't cover these codes, and that takes you back to the insurance. It really takes you back to the owners of the insurance companies. They're the ones, the ones who are deciding where the money's going to go, I guess. That's the best answer I can tell you. Why isn't it covered? Because they're not letting it be covered.
Right.
And that's the simplest answer I guess I can give you.
Okay. In your article, CRPS and the Dentist, you state that diet, exercise, and the AG and TC, which is the auricular nerve block and transverse nerve block, to best exercise and those nerve blocks to best deal with symptoms affecting the sympathetic nervous system. Can you talk a little bit more of why the diet and exercise and that together is such an important thing to do?
Yes. So again, when you treat crips, you got to surround it. And I always tell people it's like you got a crazy dog in your backyard, and you got to surround it, get a bunch of leashes on it, and get him back in the doghouse. So how do you do that? The nerve blocks can start to calm the sympathetics down. You liken sympathetics in massage or exercise. It's like opening up your pool. When you turn the pool pump on, it gets the water circulating, but you still have the debris around the pool from the whole wintertime, let's say. So you got to brush those things off, get it into circulation, and then get it out of there. So it's the nerve blocks that start to get things moving, but then it's the exercise that's going to get all these noxious chemicals. When people have crips and they have pain, you get a buildup of chemicals in these areas that have had this vasoconstriction, and the blocks will let the blood vessels dilate, but you got to get blood supply back into the area, and that's done with exercise. And then the other part is the diet, is just the crips diet. You just don't want to take in foods that are going to cause the sympathetics to stay active. You want foods that are going to calm things down. And if you look at that crips diet, you'll see there are foods that have a calming effect on the central nervous system, and then you have the foods that are going to more ramp up the sympathetics. You know, the enemy of crips is chocolate, all your sugars, alcohol, hard cheeses, red meat. It's all the thing. Everybody starts moaning and groaning when they hear that. But you know what? It's not for the rest of your life. It's just to get this under control, and or when you have a flare-up, is what I tell people. So you've got to be prepared to make a commitment. If you have this problem, you have to accept it at this point, and then let's attack it. But the mistake that gets made is you can't just do the diet. You can't just get physical therapy, or you just can't get blocks, or just go on medicine. You've got to do them all and all at the same time. That's how you have a chance to get this under control.
So if I have a CRPS flare, these blocks that you're mentioning, how does that help the flare, or is it? Should I be doing these blocks consistently?
No,
go ahead.
That's a good question. It depends on where your flare-up is and what the nature of it is. You know, if your flare-up is extreme headache or swelling, and it's from my end as a dentist, if it's hitting the upper torso where it's the brachial thermatome, which is, you know, rib cage and up into the head, neck, and face, these nerve blocks will catch those. And I'll tell you, I get trickled down into the feet. Some people come in, my feet are killing me, my feet are swollen. And I've also got my hand is swollen, and my hand is stuck, like it's either stuck open or stuck closed. And you do these blocks. I tell people, I cannot tell you how far it's going to reach. I can only try. What I can tell you is these greater auricular and transverse cervical blocks, they're going to hit everything to the head, neck, and face. That's the carotid thermatome, the one from the neck and head. But what you cannot predict until you do it is the microvascular spread of the sympathetics, because they're traveling along arteries. So every artery that has a sympathetic nerve on it can go to a spot, and then just all of a sudden they just start connecting to each other, and you never can tell how you're going to get what kind of relief you'll get. I've had times where I got relief all the way down to the feet for whatever symptom they had. I had times where it didn't reach it, you know, and the only way to know is to try. But when that happens, that's where do what you can with the blocks, and then look at their medicine, what they're on. You know, if you're on a nerve-regulating medicine that's Neurontin or Lyrica, we might up the dose a little bit if you're really getting into a flare-up. We can adjust that. If you're getting into more inflammatory swelling and skin alterations, we might go more anti-inflammatory. Sometimes it's corticosteroids like Medrol. Sometimes it's just Advil. I'll tell everybody, in a study published in 2013, what are the best NSAIDs, non-steroidal anti-inflammatories, for treating CRPS because they cross the blood-brain barrier. Your brain has like a screen protecting it from chemical invasion, and we figure out what medicines can cross it to help. So Advil, over-the-counter ibuprofen, crosses the blood-brain barrier at a very high level. But what people have to do is take it properly. The mistake that gets made is they'll take 2 Advil and they'll tell you it didn't help. And what you have to do is take at least 600 to 800 milligrams 3 times a day. So that's 3 tabs, maybe 4, 3 times a day for 7 to 10 days, not forever. But you take it and let it work for you. And with that nerve block, with that PT or massage and such, and it depends on what the symptoms are. Is it pain? Is it swelling? Is it nerve pain? Is it muscle spasming? Depending on where it is.
What about the CRPS rash? Because I know I get that. What is that exactly?
Yeah. Where are you getting it? You're talking about one part of your body. It's never the whole body, from what I've seen.
No. I usually get it like on my jaw lines, very once in a while on my hairline, and when it's really bad, it goes down in my arms and my chest.
Right. So look what you're describing. So there's your carotid dermatoma and the brachial dermatoma. So first thing you have to do is say, what happened to precipitate it? And usually, I can tell you, I always prep my patients. You got to, you educate them like we're doing now. So they say, watch out for some event. It could be, I had a fight with the boss. You dropped a book on your foot. It doesn't have to always be a cause and effect to the area. It's just whatever triggers the sympathetics. And if your sympathetics are dysfunctional, even if you're in remission, there's always a risk of remission and relapse. So now, when you have your flare-up, it could show itself as the rash that you're talking about, or it could show itself as a spasm or swelling, and it could be in any part of the body at once. If you get the same thing consistent, then you can anticipate it a little bit. And that's where anti-inflammatories could come in. And I would definitely, if it's into the upper torso and head and neck and face, I would definitely nerve block it. I would hit it every way I can to help it calm it down. And then be wary of what triggered it. You got to always study what was your trigger, because usually there's going to be a trigger. It doesn't have to be, but usually when I start asking people, okay, what's happened to you in the last night, today, the day before, and usually there's something that they'll start thinking about. It could just be an argument, and you just got a little annoyed, and
well, sometimes it's even the weather. Yeah, it's the weather, and I wanted that.
That's exactly right.
Yeah, I also feel like I'm a human barometer. Like my hands will swell up. I start puking when it's really bad flares. I'll start breaking out my CRPS rash. It's bad. So why do people? Go ahead.
Right, I was going to say, sorry, because the people who have CRPS, that's vasomotor, that's thermal dysregulation, meaning your body is not balanced properly with regard to body temperature regulation. So patients with CRPS are very sensitive to weather changes, especially cold, because what does cold do? When you go out in the cold, you vasoconstrict. Cold causes your fingers to get white and pale, and your face can get white and pale because it's causing you to vasoconstrict, because the body wants to preserve heat. Unfortunately, if you have CRPS, you're feeding into the system of the CRPS by being out in the cold. So my patients know in the wintertime here in New York, head scarf, body, face scarf, neck scarf, protect your nose, protect your any membranes, mouth and nose and ears from getting cold, because the cold will cause a constriction. It can cause an irritation, inflammation where you don't have it. And that can lead to your sinuses being irritated. It can lead to the ears leaking. It can lead to your throat becoming really sore, even though you're not sick. It's just the reaction you get from the sympathetic dysfunction. So the rash is just a trophic or skin disorder. Your hair can slow off, your nails could slow off, your skin can get irritated. And the skin irritations can be prickly rash, boils. It can look like blistery. I've seen all kinds of different types of rashes, or skin alterations that occur. And when they do, you go after it. And I'll tell you, my patients know they can reach me quickly, because I want to hear what's going on and get them in fast and start to act on it. And that's for myself. That's my commitment to helping these people.
Right now, we have the sensory somatic distribution photos that you gave me. Can you explain those a little bit of what they are? We have both of them up.
Right. So if you look at the sensory somatic one, what that's showing you, if you compare it to the thermatomal one, the way you distinguish sympathetic dysfunction, one of the ways you diagnose it is when you have a problem. If you look at that sensory somatic chart, look at how many nerves it takes to innervate from your arm, from your shoulder to your fingers. You got all your cervical, spinal nerves, and even thoracic T1. So if somebody comes in and says, oh, I got this pain in my shoulder, my hands are swollen, and I've got this spasming and such, what are the chances of having a problem with all of those cervical spine nerves at the same time to create that type of problem? And that's not going to really give you this the swelling and the rash and such, and then muscle spasming. Whereas if you look at the thermatomal diagram, you can see that a thermatome grabs that entire area, represents the sympathetic dysfunction, and then know that sympathetic dysfunction can give you high-level pain, can give you swelling, spasming, numbness, skin alterations. And the idea is to see that when it's sensory, it's a nerve to an area left side, nerve to area right side. When it's CRPS and sympathetic, unfortunately, the sympathetics can talk to each other. They can talk high to low, meaning head to toe, and left to right. So that's why symptoms can literally jump from one part of the body to another, and also change in exactly how that's going to hit you. It takes you back. It's called a disease with a mind of its own. And I know you said it's the suicides because people become despondent. Part of it's because they can't, find help, or unfortunately, when it goes unchecked for too long, it becomes so centralized that it becomes harder and harder to control, which takes you back to early diagnosis, which is why the Budapest criteria should be, required reading of everybody. It's not complicated. It really isn't. It's just it's a clinical diagnosis.
Right. There's a lot of people asking, where are you from? If they could have your contact information. Now we do have it on www.cawnetion.com, and it is under Dr. Gittleson's bio. But would you mind telling us over air, on the air too, and how they can find you or in your website?
Let me give you sure, absolutely sure. I'll give you my website. It's www.Dr. Glenn, Glenn, Gittleson, Gittelson, TMJ.com. So www.drglenngittlesontmj.com.
Okay,
that'll
I just
take
put
you
that
to
up.
my website. Okay, thanks. You'll see a whole drop down on the home page about CRPS. You'll see that the original Hardin article, it's a 50-page article. You can read it. Underneath that is a summary of the Budapest criteria that I've been talking about. The article I just had published is in there. The treatment modalities I talk about in there. There's the whole thing on jaw joint diagnostics. My office phone is 516-771-8777. And I'll give you my email. Anybody who wants is gl301@aol.com. If anybody has a question beyond tonight or wants to talk further about something, I promise you I get back to everybody as I can.
Okay, great. I just posted it also on our YouTube live chat, so everybody is seeing it as well. And again, you could get it off of our website, or you could just go to Dr. Glenn Gittleson's website. Thank you so much for sharing all this information. A lot of people are saying, "Wow, he's a real doctor. He actually knows what he's talking about." Because so many of us go into our dentists and doctors, and they'll say, "Oh, we know what CRPS is," but you could tell very quickly that they don't. And how can we get our dentists to learn about this information, and why don't they know?
You look for me, and again, I'm talking about for myself. I see it as something that caught my eye many years ago, and I can just give you one other quick story. My own mother, it's about 3 years ago now, was misdiagnosed with lymphatic cancer. She was told she had lymphoma, and because she had lymph nodes popping her neck. And here's something we didn't talk. There's two things we didn't talk about yet, if you don't mind. The immune system can become affected by CRPS. We know. My mother just popped lymph nodes in her neck, and they were loaded with T cells, and they said, "You've got cancer." Every other test they did beyond that, pages and pages of different types of blood tests, all were negative, yet they kept calling it cancer. And I politely was trying to explain to them that, listen, this is showing more signs of sympathetic dysfunction than it is cancer. And my mother's symptoms all of a sudden exploded. She happened to be nearby when it happened. Horrible pain in her shoulders. One hand swelled up like you beat it with a hammer. The other hand was twitching, and her head was sweating on one side. And I just brought her into my office. I blocked her. The first set of blocks, she got about 75% relief, and then I blocked her consecutive days, introduced medications, and by the 7th day, she was normalized again. And for the last 3 years or so, I've had to block her from time to time, change and adjust medications as necessary. But the oncologist in this case had no idea about CRPS and had no idea about the immune system involvement. And they were politely questioning, and we were talking, and they said, I said, how do you call this cancer when you have no positive cancer test? And they said, how does CRPS explain the T cell spike? I said, stage 1 CRPS, you have a hyperimmune T cell response. It's part of CRPS. And their answer was, I never heard of that. And I said, well, you know what? We all help each other. But the bottom line is a perfect example why you got to educate the public and the doctors as to this. So how do you learn? You you learn. You learn either through accident or with intent, I guess. There aren't that many places to learn. My training, I make no bones, is the Piper Education Research Center. That's where I first learned about this, and that's where I continue to learn, plus my own studies.
Now, is there...
Yeah,
go ahead. I was just going to ask, is there a set protocol for CRPS or no? No, I mean, like, where do people learn it? I mean...
The treatment protocol is from the work of Hushman. Hushman has his book. I think I had sent that to you, the link for Hushman's book. You can order on CRC Press. Yep. That's a great book. Dr. Hushman was one of the real early geniuses with his insight into treating CRPS. He was out of Florida, and the Hardin article. Anybody, if you go to my website, you can see the article. You can download it. He actually tells you in there explicit that you've got to hit this thing in multiple ways. You can't just do one. It's not something. Believe me, I didn't make this stuff up. I'm just the one trying to A, teach it, and B, I practice it every day. But I'll tell you, it works. Does it work on everybody at 100%? No, there is no cure. Even though some people tell you they can, if you catch it super, super early, which is really hard to do, you might have a chance at cure because it hasn't centralized. But the goal is long-term abatement. If you can get people's symptoms shut off for an extended period of time so they have quality of life, that's what it's all about, where they can function and have quality, then that could be called a cure until their next flare-up. And then when that flare-up happens, you get on it. You attack it fast and hard. And again, I educate my patients as much as they tell me what's going on. I make it clear to them that you have to watch out for these things. And when it happens, to let me know.
Has any of your patients that has done this diet and these blocks, have any of them found to go into remission at all?
Go into remission?
Mm-hmm. Has any of your patients been able to go into remission by doing, the diet, following the Budapest criteria, and then getting your blocks? They have.
Yeah.
Okay.
Well, the Budapest criteria is your diagnostic criteria. The protocol for treatment is the remission. You can try and get it for. I mean, truly, with the warmer weather coming up now, everybody starts to get better and stay better longer. The cold is the worst time for everybody, and that's when people tend to have flare-ups. And they know, or sometimes they'll go off the Crips diet for a little while, things like that, because they want to enjoy certain foods that they should. It depends on how susceptible they are. So can you get remissions? Absolutely. I do it all the time. Can you get cure? No, because cure implies you'll never have it again. There's no way you can tell that to somebody because it's a disease of the sympathetic nervous system, which is part of the autonomic nervous system, which is part of the central nervous system. You're not going to get rid of it, but you can abate it. And the longer you can get between episodes of relapse, the greater you can call that at least I don't want to use the word cure. You extend the abatement period. You extend their time in remission as best you can. And they know, be careful. Watch out for stress events because stress will make you sympathetics activate. Watch out for mechanical events, as far as tripping and falling and bunking and things like that. People do stuff. You live in your life, and if something happens and it kicks it up, the main thing for me is I tell people, get to me fast, so we can get right on. Don't wait. It's like saying I have 101 fever. Don't wait to have 104 to tell me now you're really sick. Don't wait for it to get that bad.
Right. Tammy Harris wants to know, how long is the wait to get in to see you?
I try to get people in within a reasonable time. Nobody waits more than a week. If someone's really in an acute problem, if we have to, my staff knows we stay after. If I had to, I'd come in on my day off. Nobody waits who's suffering. There's no it's not a 2-month or 3-month wait or anything like that. At best, if somebody really had to get in, I'd get him in the same week. If we had to, same. It depends on how far away they are and where they're coming from and what do I have to do. It depends. I always like to speak to people on the phone briefly when they call up so I can just get a quick assessment as to what's going on. I want to make that call. And I say, listen to my staff, we're going to bring this person in, and I think we're going to stay after for this one. Let's get her going. Let's get our imaging and things set up. And so the quicker I can get on it, the quicker we can start to hopefully try and get things under control.
So say
nobody waits
I'm a patient.
If they don't have to wait. What's that?
Right. Say if I'm a patient and I'm coming to see you, I'm coming in from out of town, so I'd probably get a hotel. So explain, you like the patient to stay there for a few days, right? And can you explain, how long I'd be there, what happens over those few days?
Right, so that's fair. So that's why I like to speak to people over the phone, and even though my website sort of explains what we do, I like to hear from people exactly where they are, because if you're really truly in an acute episode, I'm going to tell you to come in and be prepared to stay for a couple of days, because I might want to block you multiple consecutive days while we start, medication, while we start physical therapy massage. I actually have a physical therapy massage chair. It's one of these giant chairs that does vibration, compression, the balls that roll up and down your back, and heat. It's just a way to get circulation going. If you do these nerve blocks and go right into the chair, you can get more profound relief, assuming they can tolerate that. But depending on how, that's why every patient is individual. There's no cookbook with this. I have a protocol I'll follow in my diagnostics, and I got to get, if there's been trauma, I need to see MRI of the joints and cervical spine. But I can pre-cert the imaging I need and get the imaging done within a day and institute my blocks and treatment. So the idea is I want somebody to stay long enough to make sure what we're doing is working. So if you're out of state, before you go back, you know everything you got to do, and we set up a working communication. Because I can't tell what's going to happen when you get home. I can only tell you that when people have left with the blockades in effect, and especially with Marcaine, they'll give you a good sustained effect, that they're able to get comfortable. The goal is, if you shut the pain down, if the pain is the dominant symptom, everything else will start to shut down. Here's something else we didn't talk about real quick. The other problem that CRPS patients have is they're insomnic. They have insomnia where they can't sleep well. They have mental confusion, agitation, things like that. And that's because the limbic system of the brain is where the sympathetic nerves terminate, and that's your emotional center. So very often patients with CRPS, either their significant other or they themselves know, I can't sleep well, or their mental focus is down. They have personality changes and things like that. And that's all signs of the limbic system being involved. And again, you have to go after those things. But if you start to take away some of the triggers that they have, if you start to take away some of their symptoms, if you start to show them that there's hope to get this at least somewhat under control, maybe not 100%, but what if we just cut everything in half? That makes them feel better. Just to know that they know what they have. So many people come in undiagnosed, misdiagnosed, and mistreated, and all of a sudden you give them a thought process and a plan of attack, they start to feel better just from that, because at least they know what they're dealing with, and you have a way to handle it.
Yeah. What about, I wanted to ask you too, when I'm going into a flare, sometimes I get sensitivity to like light and vision and hearing, and it seems to come and go. Is this part of a normal thing that happens with CRPS patients?
Well, I wouldn't call it normal. That's your hyperesthesia. Hyperesthesia is increased sensitivity of your senses. So when you get a flare-up, if it's going to hit you that way, because remember, you're going to have sympathetic nerves that are going to track right to the eyes, track to your sense of smell, track to your ears. So when you get a flare-up, you could have trouble with light making you want to wince away. Sounds, it's hyperacusis, it's called. It means that this crackling noise is agony to you, or any rustling noise is very antagonistic. And terrible with dentistry is even when somebody has hyperesthesia of the skin, people who can't even take their own skin against their body laying down. Or you go to give them an injection, and as gentle as you try to be, they're just in agony because they're hyperesthesia of the skin. So that is a sign of a flare-up. And sometimes that is the main symptom, and then you know what you got to do. So stay away from those triggers, because as soon as you get that trigger and you wince from that pain, you're going to stimulate the sympathetics, because you're responding with that flight and fight response. So you take away the triggers, and start to treat it. Treat it however you can, and hopefully keep it contained. Don't let it spread. That's why as soon as you get into a problem, you got to go after it multiple ways. Sometimes I'll tell somebody up the medicine. Sometimes I'll add something else. It just depends on how they're getting their flare-up. And for me, it's just like everybody can reach me. All of my patients have my cell phone too, because I want to text me, and just I'll get back to you and let me hear what's going on. That's why if somebody's in trouble, I call it in trouble. If they're having a flare-up or they're new, I don't want anybody to wait, because that's my commitment. I want to help you. I want to get you under control if we can, as much as I can. Just depends on how bad, how centralized the CRPS is, how long you've had it for. That's all the history taking. There's a tremendous amount of paperwork, documentation that patients fill out to map out all their signs, all their symptoms, the history of what they've had done, past medications, current medications. All those things paint a picture. And it all goes into a template that I then project onto a screen. So when we sit down and go over everything, everybody's on the same page as to what I'm thinking, and that they understand everything as well.
Well, Dr. Gittleson, Man, I appreciate you coming on so much, and so does our audience. Is there anything else you wanted to share with us before we get going here? We have to wrap up.
No, just anybody who was listening, if you have a question, I gave my email. Send me an email. If you want to call the office, you're certainly welcome to, and leave a message. I'll always try to get back to you. Or if you send me an email, send me your phone number, and I'll call you back when I can. I usually do that in the evenings. I'll try to always help and answer questions or just guide you as best I can. And also, if anybody wants, I can fly or drive anywhere to give a presentation on this material and try to educate either the public or any doctors who would be interested in learning. That's the best I could offer to you.
All right. Well, thank you, Dr. Gittleson, for joining us this evening on Call Nation. We really appreciate it. And again, I just want to give your website again. It's www.drglenngittelsonTMJ.com. And his office number is 516-771-8777, and his email is gl301@aol.com. If anybody has any questions, you can get a hold of me and just let me know, and I'll give you the information again. Again, just thank you so much, Dr. Gittleson, for joining us. And also, I just wanted to give a quick reminder to tune in Sunday, April 7th at 6 p.m. Eastern Standard Time for the DPP Rally Talk Show with Claudia Miranda. We are not going to be doing a live show because of the holidays, but we will be re-airing Rhode Island Representative Greg Moore that she had on. And again, a big thank you to our audience for taking some time out of your evening to join us here at Conspiracies Against Wellness. I'm Janelle Elgaway, signing off until next Tuesday. Have a great evening, Call Nation.
Listening to Conspiracies Against Wellness with your host, Janelle Elgaway. The opinions expressed on this program are those of the hosts and callers, and not necessarily those of EXG LLC, its employees, or sponsors. Copyright 2018 by EXG LLC. All rights reserved.